And Theresa comes to us from Brown University with a Bachelor of Arts in Art History and a minor in Gender Studies. Theresa also holds a MS degree in biotechnology with a concentration in bioinformation from Johns Hopkins. So Theresa, welcome.
Thank you. So my name is Theresa Boyer, and today I will be talking to you about the variation and correlates of psychosocial well-being among women with preeclampsia in the new mom-to-be cohort. So preeclampsia is a hypertensive disorder of pregnancy that affects about 5% of all pregnancies, and it remains a leading cause of maternal and neonatal morbidity and mortality. Earlier research viewed preeclampsia as a monolithic disease originating from abnormal placentation. But probably a better way to look at preeclampsia is to see it as a heterogeneous condition. While known predictors of preeclampsia encompass maternal pre-existing conditions, things like obesity and diabetes, we know that Black women and women of lower socioeconomic status have an increased risk for preeclampsia. This suggests the role of individual and system-level stressors in disease origin. However, we still know little about how maternal psychosocial well-being interfaces with these lifestyle and structural factors. Given the heterogeneous nature of preeclampsia, this could provide insight into future preventive strategies and improved patient care. So the aims of this study were to firstly identify and estimate the prevalence of social stressor landscapes among women with preeclampsia. And secondly, to examine the demographic characteristics, health behaviors, and health system level correlates predictive of psychosocial well-being. We drew our sample from women who developed preeclampsia within the new mom-to-be cohort, which was a multi-site prospective study that aimed to identify risk factors for adverse pregnancy outcomes among nulliparous women or first pregnancies. Study visits occurred at 4 time points with information collected spanning the pre-pregnancy to postpartum period. We used an adapted version of the National Institute on Minority Health and Health Disparities research framework to conceptualize how psychological and sociocultural domains influence social stressor exposures on an individual level. From this framework, we selected observable or manifest variables that captured these domains. These included categorical measures for stress, anxiety, resilience, depression, social support, payment concern, and racism. With these indicators, we use latent class analysis, a type of finite fixture modeling, to describe our unobservable latent variable, which was the social stressor landscapes during pregnancy for women who developed preeclampsia. Next, we use multinomial regression to estimate demographic, health behavioral, and health systems level correlates of latent class membership. All of our indicators and correlates were measured in the pre-pregnancy period or prior to 20 weeks of gestation. In terms of the sample composition, the participants were well educated. 66% had access to private health insurance and 57% were non-Hispanic white. And the sample was relatively evenly split between mild and severe preeclamptic subtype. Since our manifest variables comprise psychological and social dimensions, we theorized our latent classes as gradations of psychological well-being. 53% of the sample was in the intermediate psychosocial well-being class with low probabilities of either the most positive or negative psychological indicators. 31% of our sample comprised the positive psychosocial well-being class, characterized by higher response probabilities for the most positive psychological indicators. The negative psychosocial well-being class represented about 16% of the sample and had high probabilities of negative psychological indicators. All classes had low probabilities of poor sociocultural indicators. Our findings do differ from the results of an earlier published latent profile
I'm not.
examined psychometric indicators among the entire new mom to be cohort. And in this particular analysis, about 68% of the full cohort approximated our intermediate psychosocial well-being class, while the remaining 3 classes had mostly negative measures for depression, racism, and social support, respectively. In terms of class composition in our unadjusted results, we noted that our classes differed on markers of social advantage, so things like age, education, and health insurance. For example, women in the negative psychosocial well-being class tended to be younger, had less education, and were less likely to have a partner compared to the other classes. And there were also a larger proportion of non-Hispanic Black women in this class as well. We noted no differences between classes in terms of pregnancy characteristics, including preeclamptic subtype, birth outcome, birth weight, and gestational age at the time of study visit, as well as delivery. Moving to our multivariate results, we surprisingly did not see any differences in demographic characteristics like age, race, ethnicity, and maternal education when we compared the intermediate and negative psychosocial well-being classes to the positive class. And while there were differences in the unadjusted results, as I previously noted, adjusting for educational and health behavioral compositional differences seemed to account for this. When we investigated behavioral characteristics, we observed behavioral characteristics indicative of exposure to chronic stress among women in the negative and intermediate psychosocial well-being classes. This included an increased risk of poor sleep quality in the negative psychosocial well-being class compared to both the positive and intermediate psychosocial well-being classes, supporting the known association between poor maternal sleep quality and the presence of chronic stressors. Additionally, the magnitude of this was quite pronounced, with around 7 times the risk of poor quality or inadequate sleep compared to adequate sleep. Despite adjustment for demographic characteristics and health behaviors, women in the intermediate psychosocial well-being class were more than 1.8 times as likely to be morbidly obese than those in the positive psychosocial well-being class. Increased risk for morbid obesity within this group may reflect a more direct physiologic manifestation of chronic stress exposure. An interesting finding in our health systems correlates included the persistent concern about the quality of medical care along gradations of psychosocial well-being. Compared to women in the positive psychosocial well-being class, women in the intermediate psychosocial well-being class were 3 times more concerned, and women in the negative psychosocial well-being class were 6 times more concerned about the quality of medical care that they would receive during pregnancy. It is also notable that this poor perception of medical care was recorded prior to the diagnosis of preeclampsia and remained significant after adjusting for health literacy level as well as race and ethnicity. This distrust of the medical system may relate to the markers of social disadvantage and chronic stressors that we observed within these classes. In conclusion, although prior research indicates that psychosocial stress is a risk factor for preeclampsia, we found important variation in the social stressor landscapes of women who developed preeclampsia in the new mom-to-be cohort. Notably, a majority of the sample had either positive or intermediate psychosocial indicators, showing that women who develop preeclampsia are not an overwhelmingly disadvantaged group, but rather experience different intensities of internal and external stressors. Our results further highlight linkages between psychosocial well-being during pregnancy and potential modifiable factors. For example, the most disadvantaged class had behavioral markers of chronic stress, including poor sleep quality, while the intermediate psychosocial well-being class exhibited higher pre-pregnancy BMI. Both of these classes were also characterized by a mistrust of medical care received during pregnancy. Future studies should continue to investigate the biological and behavioral implications of exposure to acute and chronic stressors, as well as the consequences of poor perception of medical care among women with preeclampsia. As nulliparous women, this medical mistrust may be an important determinant in driving disparities in subsequent pregnancies, as well as later in adulthood. I would like to thank both of my readers as well as my advisor for their assistance throughout this process, as well as all of the patients who participated in this study. Thank you.
Wonderful job, Theresa. Thank you so much. So I will now open up to questions. And so feel free to either raise your hand or go ahead and unmute yourself. And I will do my best to see who's on board. And just to let you know, I'll prioritize students first. So any one of you have a question for Theresa? I'm looking at the chat too. So feel free, if you don't want to speak, you can also use the chat. Okay, guys, there's got to be a question. I have a question, but I want to make sure. Okay, David.
Yes.
Yes.
Thank you. That was wonderful. Wonderful presentation. Just one thing, one area I wanted to explore, and that is you looked at quality concern within the population, and then you used the term mistrust. Are they both the same in terms of the metric, or is there a distinction of any significance, or you just blend the two?
So the actual measurement in the study was about being concerned for quality, which we interpret as an indicator for poor perception of care. So I guess I extended that to mistrust during mistrust of the medical care that you would receive.
But since these were stressed and individuals who had less access to health care or education, it may not necessarily be mistrust. It may be ability to get the care that they need.
I think you could say that maybe for the most, for the negative psychosocial well-being class, but really we saw this increased concern as well in the intermediate class, which didn't have necessarily a strong markers of social disadvantage.
Thank you. So mistrust was a interpretation.
Yes, that's correct. And also through doing this research, I realized that there are all different scales and measurements for mistrust when you receive medical care, which was also interesting. There's not really a standardized way that people are measuring it or defining it.
Thank you. It was a wonderful presentation.
It was. Thank you, David, so much. Other questions? Wow. Okay, so I'm going to ask a question. Theresa, does it matter, and I don't know if you looked at this or not, but the type of provider, because there's lots of different healthcare providers for women in this, and I'm just wondering, did you get at that, or was this just kind of?
Yeah, that would be really interesting. It's interesting. There are about 10,000 variables that are included in this study, but the type of provider is not one of them.
Oh, okay.
Yeah, but all of these women delivered at major academic medical centers. So I would assume that there could be less variation in the type of provider than someone would maybe get in a more community setting.
Yep. Okay, great. Susan asked a question in the chat is, what was the timing of sleep for the participants?
The period measured, it was in the 4 weeks prior to the first visit. So they would have been very early in the first trimester.
Okay.
Yeah.
Okay, great. I'll give 1 more minute, or maybe not that much, but maybe 10 more seconds in case anyone wants to raise their hand. No. Okay. Well, Theresa, thank you so much. Wonderful presentation. All right. So next is Mona-Esmat Jarrah, Mona, I've known for a while. She was my TA for my fundamentals class last year. And so I've seen a little bit about this. So I'm very excited to see her presentation. The title of this is actually called Picture This, Identifying Barriers in the Home Environment Among Families of Children with Medical Complexity. Mona comes to us from the University of Toronto. She has a Bachelor of Science and she majored in population health and neuroscience. So welcome.
All right, thank you everyone. And thank you so much, Theresa. That was such an interesting presentation. So hi everyone, today I'll actually be presenting findings from a qualitative study that used photo voice to identify barriers in the home environment among families of children with medical complexity. And throughout this talk, you'll see photos taken from the study and we have permission to show them, so full disclosure. So first off, our target population for the study is children with medical complexity, or CMC. Now, CMC fall under a broader category of children with special healthcare needs. And within this broader category are a subpopulation of children with the most complex intense care needs, referred to as CMC. And really, they're characterized with having chronic and severe health conditions, impaired or limited functional abilities, and high healthcare service needs. Now, importantly, due to these functional limitations, CMC and their caregivers often face challenges with accomplishing activities of daily living, or ADLs, such as feeding, grooming, toileting, and so on. And prior studies have shown that CMC experience increased ADL challenges compared to their healthy peers. Now, additionally, the home environment is a vital component for CMC because it impacts the ability to actually exercise these ADLs and provide sustainable care. Unfortunately, families of CMC have been shown to be disproportionately affected by housing needs. So, for example, a study done by Esser and others found that compared to families with healthy children, CMC families were 3 times more likely to report a safety concern in the home and 5 times more likely to report using a common area for sleeping, which you can actually see here. One of our participants did this by converting their dining room into their child's bedroom with a makeshift curtain. And so, although existing data clearly shows that these families face numerous housing challenges, published literature regarding housing need for CMC still remains limited. And as such, the objective of our study was to capture, through photo voice methodology, how barriers in the home can actually limit the functional abilities for CMC and impact the overall well-being of the child and family. So photo voice methodology was used in the study to capture the lived housing experiences that CMC families face in everyday life. Photo voice is a qualitative method that is commonly used within community-based participatory research, and it utilizes photography to document, reflect, and discuss the reality of participants. And so a little bit of recruitment here. In partnership with Parents Place of Maryland and the Coordinating Center, we recruited CMC families in Maryland, and then we sent out a secure web-based link through Qualtrics for families to complete a demographic survey and upload up to 10 photos of their home. Now, importantly, these photos represented both barriers and facilitators to caring for CMC, but for the purposes of my essay and this presentation, I'm just going to focus on the barriers. And so after participants completed the survey and uploaded their photos, semi-structured interviews were conducted to really engage in active discussion of the shared photos. So the interview questions, some of which you can see here on the slide, were really developed to try and understand what the participant intended to show with that particular photo and what impact the photograph has on the lives of the child and family. So now turning on to data analysis, our team first reviewed all photographs and associated transcripts where participants actually identified a barrier. And then we created a spreadsheet for those photos and extracted the relevant transcript text to describe those barriers. Now, in order to guide our analysis, we used a deductive approach of really wanting to ground our results to an established ADL model. And so from this, we used the Roper-Logan-Tierney model for nursing, specifically because it describes how factors in the family's environment, in our case, the home environment, which you can see in the red circle over here, can impact a child's ADLs across their lifespan, which in turn can impact their independence as well as other aspects of their lives. Now, importantly, out of this list of ADLs in this model, we chose to include the 6 most pertinent to this pediatric population, which were feeding, grooming/bathing, toileting, mobility, play/learning, and sleep/rest. Additionally to this, we also used an inductive approach to identify further thematic coding within each ADL category to describe the impact that's captured by the photo and its representative code. So for example, one ADL barrier photo can have an impact on both the child's safety and the child's independence. And so as we coded through the transcripts, our study team went back to update this code book. And through this iterative process, our research team identified a total of 16 different applicable impact codes across all of our ADL categories. And so this served as our overall code book. Now, turning over to the results over here, to date, 11 interviews were completed. And while our participants were majority female, white, and homeowners, they represented a broad range of education level, income status, and a diverse mix of rural, urban, and suburban housing. And looking at the child characteristics, overall, the children ranged in ages from 5 to 20 years and had a variety of complex medical conditions. Now, moving on to the participant photos in relation to the ADL categories, among the 109 total photos uploaded by the 11 participants, 59 photos captured a barrier. And using our deductive approach across the 6 ADL categories, the majority of photos and illustrative quotes were categorized under mobility, followed by grooming/bathing, play, and so on. And additionally, using our inductive approach, 4 impacts that were mentioned the most by parents across all of these ADLs were the child's safety, the child's ability to exercise independence within the home, the parent's ease of care, and also the child's access to the home. Now, for the purposes of this talk, I'll only have enough time to highlight the 2 most common ADL categories, but I'm happy to show photos and quotes from the other ADL barriers during the question period. So taking a deeper look into the most reported ADL, we see that with mobility, many photos were related to stairs and uneven flooring. And the majority of impacts that were mentioned under mobility were, again, the child's safety of falling down the stairs, the child's independence of going up and down the stairs alone, the child not having access to even go up and down the stairs, and also the parent's ease of care of having to carry the child up and down the stairs each day. And one quote over here that highlighted the impact on access, also on parent ease of care, and the child's ability to engage with the family was this one participant who stated, "I chose this photo because it plays a big part in functionality and where to go." So it's like, if mom's not doing okay and not feeling like lifting a lot of my son up and down the steps, then the child is going to be up there for the day. Now, for grooming/bathing, major issues voiced by parents included the narrowness or depth of the bathtub, which actually impacted both the parent's ease of care and also the child's safety. So here's another quote from another parent that said, "Using the bathtub itself is becoming challenging because it is deep. It's like a jacuzzi set tub, and she's dead weight. So it's difficult without 2 people, one to lift and the other person standing there to receive her to actually get her out of the tub." And so from this, we can really see the impact of ease of care being highlighted. Now, interestingly, many parents describe potential solutions to addressing the barriers in their home, such as installing a walk-in shower. However, when asked about the challenges to actually implementing these solutions, parents universally mentioned financial constraints as being a major challenge. Some other challenges that parents mentioned included a lack of available housing resources, long wait lists to receive housing services, contractors not really knowing what modifications to do that are CMC specific, and challenges of homeowners being able to do modifications, whereas renters cannot. And so just a quick mention on some strengths and limitations here. One of the major limitations to the study is generalizability, in that all families lived in Maryland and no participants lived in apartments. So these results may not be applicable to other environmental landscapes. But on the flip side of this, one of our major strengths was gaining perspectives across a broad age range of children, which really allowed us to capture home barriers across multiple stages of life for this target population. So in conclusion, findings from our study indicate that the home environment is a vital component for CMC to execute basic activities of daily life. And again, the major impacts noted across all of our ADL categories were safety, independence, ease of care, and access. And this is important because it suggests that creating feasible home modifications that can actually target these core impacts may potentially maximize the overall well-being for CMC families. And so looking to future actions on the last slide over here, there's many potential next steps. One of them is looking at piloting a home modification program. And in fact, based on this preliminary work, our study team was able to secure funding to pilot such an intervention. And again, more than happy to talk about that in our question period. But for now, I'll say thank you so much. And again, such a big shout out to my supervisors, Becky and Pam and Laura and Brandon, for all of their support. And I believe they're here today, so thank you. And to our entire cohort, thank you so much for everything. And to my wonderful boyfriend and our cat.
Yay, I love it. Great job, Mona. This was really interesting. So let me first open it up to questions. Again, students first, but if not, anybody. Okay, there we go. Gretchen.
First of all, amazing presentation, Mona. The photos and quotes were really impactful. So thank you so much for including those, and such a wonderful dissection of the research. One of my questions was sort of how you came about choosing the eligibility criteria, specifically for like the age range being 26 and younger.
Yeah, no, that's a great question. There's a couple of reasons for that. So while working in partnership with Parents Place of Maryland and the Coordinating Center, they actually suggested that we make this cutoff. And also, I'm originally from Canada, and I think how the healthcare system works here in the US is children can stay on their parents' health insurance up until about 26 years old. And so that was another reason for us wanting to choose that eligibility criteria. And then the last reason was actually because we wanted to see if there was a difference in home barriers across CMC in different ages, in different stages of life. And we wanted to see if those home barriers could potentially differ. And so, yeah, that was basically our reasoning for the eligibility criteria. Hope I answered it.
Thank you, Mona. There's another question by Haley.
Hi, thank you. As everyone else has said, great job, Mona. I know you said you secured some funding for a pilot program, so I was wondering if you could talk a little bit more about that.
Yes. Oh, yes, of course. So the pilot program that we're hopefully trying to run is actually based on another program here at Hopkins, and it's called the Capable Program. I think it stands for Community Aging in Place, Advancing Better Living for Elders. And it's a really cool program. It integrates occupational therapists, registered nurses, and handy workers to actually examine the home setting and target feasible low-cost modifications that are patient-specific. And it's meant for the geriatric population. And what we've seen so far from this program is that it actually has a very high return on investment, especially in reducing hospital expenditures that could incur for this target population. And so hopefully what we can do is create a similar program like this, but tailor it to our specific pediatric population.
Great. One more question. Simona has her hand raised.
Mona, congratulations on a wonderful presentation. I just wanted to go back to the pictures that you showed of the ADL categories. I know you showed the mobility and the grooming pictures. I was wondering if you have other quotes or photos from the other ADL categories. It sounds super interesting if you have time.
Yes, let me present them. Very exciting. So I have a bunch here. So this is the play and learning. I don't know how much time we have, but here was our third most commonly reported ADL barrier. And so you can see some photos over here. Again, one of them of the stairs. The middle one is actually right out at the backyard of a person's home. And it really explains how the uneven ground makes it hard for their child to even access that playground. And then the last one over here looks at sort of the playtime barriers that this child has with having to lay down in the floor. But here is one of our quotes that we had for play/learning. And the participant said, "The basement was kind of where all the fun happened. It was also our school room and where we homeschool, and that's also where their Lego room is. And now she doesn't have access to any of that, which is sad." And so, yeah, you can really see impacts of really not having any access to go down there. And you can also see the impacts of child development. Should I go to other ones? I don't know if we have time.
We don't have time, unfortunately,
Okay,
but
no
how about
worries.
this? We can share this with everyone. And for those of you that would like to explore more, we could, you can feel free to use the chat, continue to use the chat, and then just email Mona for additional questions after that. So how does that sound? Thank
Perfect.
you, Mona,
Thank you.
so much. Great
Thank
job.
you.
Fabulous. Okay, so now it's time for our third presenter, Josephine Peitz. She got her Bachelor's of Science degree from Wayne State College, and she majored in life sciences and biology. And the title of her presentation is called Summarizing the Evidence for Screening and Prevention of Postpartum Depression in Rural Women in High-Income Countries. So Josephine, are you there?
Yep.
Okay, great. You can take it away. Thank you.
Yeah, thank you for that introduction. I'm gonna move this quick. Okay, and thank you everyone for being here. So I'm gonna jump right into it. So clinically and in research, postpartum depression is not consistently defined. Really, it's anywhere from 4 weeks postpartum, 6 months postpartum, up to 12 months postpartum. And PPD can occur anytime in the first year postpartum. So for the purposes of this review that I did, postpartum depression will be defined as depression anytime within 12 months after childbirth. Postpartum depression is one of the most common non-obstetrical complications and the most common psychological disorder after birth. It affects about 15.5% of women in high-income countries. And there are numerous negative effects on the mother and infant. For the mother, she is more likely to have higher anger and lower anger control, more financial problems, increased risk of homelessness, more relationship difficulties, and the infant is less likely to be breastfed at 6 months postpartum. Bonding between the infant and mother is negatively impacted, and the mother is less likely to take the baby in for age-appropriate well-child checks. And then protective factors against PPD include social support, positive family relationships, and if the woman is breastfeeding. And then there are numerous risk factors, so just some of them include intimate partner violence, unemployment, low socioeconomic status, lower education levels, marital status, and the most predictive risk factor for PPD is history of depression or prenatal depression. So screening for PPD is super important in order to catch women who have PPD or are at risk. There are numerous tools that are used, but they're not all validated for screening of postpartum depression specifically. The most commonly used screening tool is the EPDS, which is shown here as an example of what screening tools tend to look like. This one specifically is 10 questions long. It's written at a 4th grade reading level. It's available in 36 languages and validated in 18 of those languages. A typical cutoff score of greater than or equal to 12 is indicative of depression. And so the higher the score the woman has, the more likely she has depression. And then it also, like in the instructions, asks, think about how you felt the last 7 days and then answer these questions. And so I'm focusing specifically on rural women because they have been shown to have consistently higher prevalence of PPD than the accepted prevalence of 10 to 15% in high-income countries. And not only do they have higher prevalence of PPD, but they face numerous unique barriers to the screening and treatment of PPD, particularly structural barriers because of the lack of mental health providers in rural areas. There is a big spread of geographic location of the services and wait lists for appointments. Even if women can get them, then they have to worry about transportation, childcare, and if their insurance covers the mental health services. And then a couple psychosocial barriers also include the mental health stigma in rural communities and the acceptability of screening or treatments. So for my literature review, I identified my core concepts of postpartum depression, screening and identification, prevention, and rural populations. Then I performed my search in PubMed and based in PsycInfo, and the identified studies were imported to Covidence, where I screened them and then analyzed my final included studies and their major findings to identify themes between the studies. So my criteria is listed here. Just generally, I wanted peer-reviewed English language studies examining screening or prevention of postpartum depression in rural women in high-income countries. In total, 982 studies were imported for screening. I did title and abstract screening on 750 studies. I full text screened 101 studies, and in the end, 13 studies were included in my results. So there were a range of interventions that were identified in these studies. And so I divided my results into whether the intervention was for screening or prevention of PPD. So beginning with screening, during well child checks, screening rates tend to be low and maybe half of women coming in get screened. But after implementation of a program, it is possible to increase screening rates in pediatric clinics. And then women's attitudes about screening, they usually don't have a problem with being screened. Some women do feel stigmatized by being made to fill out a screening tool because they kind of think like, oh, why is the nurse giving this to me? And then some also think that it doesn't address their specific needs, but some women do believe that it opens the door for discussion with a health professional about their feelings. One of the major barriers to screening is that the mother does not go to well child checks, whether she no-shows the appointment or maybe if the father just brought the baby in for the appointment. And then also the relationship between the woman and the health professional giving her the screening can influence how honest the woman is in her answers to the screening questions. And then thirdly, adapting screening tools. There's this new tool that was developed called the Kimberley Mom's Mood Scale, and it was adapted from the EPDS specifically for the Aboriginal population in the rural Kimberley region of Australia. And so healthcare workers administering the KMMS believed it is superior to the EPDS for this population, but some think part 2 of it, which allows the woman to talk more about her mental health and life, is not practical to do given the time constraints in clinics. And then the Aboriginal women included in interviews thought the KMMS was helpful and supported implementing it across the region. And also an online EPDS screening and referral platform was discussed in an article, and they found good consistency with this version, and it had similar reliability estimates to the paper EPDS. And then moving on to prevention results, 3 studies looked at group and or one-on-one support options, and they all saw significant decreases in depression scores or depressive symptoms, and they were all found to be feasible and acceptable prevention programs to implement. Looking at technology-based prevention interventions, there was a video-delivered family therapy intervention with home visiting clients, and they saw a significant decrease in depressive symptoms. And then another intervention used phone calls from registered nurses as support, and this showed that women who were less depressed at the start of the intervention saw a larger improvement in their scores and maintained those scores through 6 weeks postpartum. And then finally, an early motherhood service, which was implemented in a clinic in rural Australia, saw that women who used this service saw significant improvements in their EPDS scores. So this shows a really successful model for a rural perinatal mental health service. So the implications of this review, well child checks are a great time to catch mothers because at least in the US, there are at least 8 recommended pediatric visits in the first 2 years of life. So there are multiple time points a woman is in contact with a health provider where she could and should be screened for PPD. But if the mother doesn't show to the appointment, sending the EPDS online could be a great option. It allows for screening at multiple time points, and it's possible women might answer more honestly if they are uncomfortable answering those questions in front of a healthcare provider. But it is possible with an online screening platform, the amount of women who would seek help and referrals might not be as high. Then thirdly, it is possible to adapt a new screening tool to be more culturally relevant for populations in order to get more timely and accurate referrals. And then we also see that women with higher depressive scores may require more effort needed to be put into prevention and reach out methods in order for them to see similar decreases in depressive symptoms as those who are less depressed. Rural women in particular face a range of barriers to accessing mental health services such as transportation, childcare, cost of services, lack of insurance coverage, mental health stigma in their communities, lack of providers in the area, and long wait lists to see professionals. And finally, even with mandatory universal screening protocols, that does not mean that there will be universal screening and treatment. And that won't happen unless we address barriers, particularly that these rural women face. The limitations of my review, the studies that I found were only done in the United States and Australia. So more research needs to be done in other countries to make sure more general recommendations for screening and prevention strategies work in those contexts. And then, as always, with studies that rely on volunteers to be part of them, and with studies using qualitative data from interviews, there's the risk of selection and social desirability bias in the studies. Many of them also excluded women who had particularly high depression scores or had past depressive episodes. And this would exclude a large population of women who are particularly at risk for PPD. And finally, with prevention studies that didn't have comparison groups, it could be hard to tease out whether the depression scores declined naturally over time, which is something that they do, or if the intervention actually played a major role in the outcome. And moving forward, more research needs to be done on this population and in this area in general. And one possible way to expand the body of research here could be using studies that are looking at prenatal depression prevention to extend their data collection to include postpartum time points to see the effectiveness of their prevention on both prenatal and postnatal depression, since prenatal depression is such a strong predictor of PPD. And then technology-based approaches are feasible and may help address numerous barriers that rural women face in accessing mental health services. Particularly with COVID, it has opened up many opportunities and shown the need for more technology-based screenings and prevention strategies. And finally, this range of interventions hold great promise for the prevention of postpartum depression and screening for postpartum depression among women living in rural and hard-to-reach regions who often experience inequities in health outcomes and care seeking. And thank you, and I can take any questions.
Thank you so much, Josephine. Again, wonderful presentations. So with that, I will again open it up for some questions. I will manage both the chat and anyone who would like to just raise their hand or go ahead and unmute yourself. Maybe while we're waiting for a question, I was just wondering, since one of the recommendations was technology, and I don't know if you had a chance to look at this, given there were 13 studies, but is there any indication about whether some areas may be more prone to that type of intervention? Because I know rural areas tend to vary with their access to technology, or was that, did you get any information?
None of the ones that I looked at really discussed that, but I know that is kind of an issue also with just generally like accessing internet and data in rural areas sometimes is really difficult, which can make it hard to do technology based interventions like these, but they really didn't discuss that very much in any of the studies I looked at.
Okay, great. There is another question by Sally in the chat, and she says, great job. I imagine the cost of services that address PPD would be a major barrier for getting women into treatment. Any ideas on how to address that?
I guess probably one of the major things would be insurance coverage, trying to get more like Medicaid, people who maybe are low SES, whatever public insurance, trying to get them to cover mental health services, but also more private insurances, also trying to get them to cover these mental health services also.
Great. Morgan is asking, when looking at interventions, did you find any research about midwives and doulas, and if having them at mothers' sides decrease PPD?
So I did not really. There were a few where the midwives were maybe the ones providing the screening at like prenatal visits. They do that just to assess risk, I think, and see if they have prenatal depression also, but not really like during birth or anything. I didn't see any of that in my research.
Any other questions from anyone? David? David, I think you just have to unmute yourself.
Typical Saturday Night Live kind of thing. In the high income, I'm really interested whether there was any income distribution within that population, even though it was rural. And I know the number of studies were terribly limited. And also whether there was any hint in the research that you did regarding leave policy in terms of postpartum leave policy and its impact on postpartum depression.
Yeah, so with the income distribution, I really didn't see very much. I'm trying to remember. I don't think they talked too much about that. It was just really kind of like lower income, higher risk, in a lot of like reviews that I just kind of glanced at for background information. Then also with the leave policy, I didn't see any of that either, but that would be really interesting to look at as well.
Thank you. It was a wonderful presentation, as all are. Thank you.
Yes, I agree. So thank you so much, Josephine. That was wonderful. And now we will get ourselves ready for the next presenter, Madeline Quasebarth, who is an MHS student. She's getting her online degree in maternal and child health. So, and she comes to us from Carnegie Mellon with a Bachelor of Arts in Anthropology and Fine Arts. She also holds an MA in Social Sciences from the University of Chicago. So the title of her presentation is Illinois Crisis Pregnancy Centers, a public health case study on state-sponsored reproductive coercion. So Madeline, are you able to share your screen?
Yes, thank you so much for the introduction.
Yep.
All right, can you guys see that all right?
Yep.
Great. All right, yeah, my name is Madeline. I use the she, her pronouns, and this topic is on Illinois Crisis Pregnancy Centers and reproductive coercion. I would like to acknowledge my two advisors, Dr. Holiday Warru and Professor Rosen, for their help. So the objective of the study was to investigate the implications of covert state-sponsored reproductive coercion within the tax code. The study uses the case study of CPCs, or Crisis Pregnancy Centers, in Illinois to highlight implications on both the demographic and financial level. Before getting started, I do want to define some key terms first off. So CPCs, or Crisis Pregnancy Centers, are Christian-based pregnancy counseling centers. Normally, they're evangelical, that are staunchly anti-abortion, and we'll go into a little bit of other health implications momentarily. Reproductive coercion is the overall thematic framing for this research. It's defined as the interference with autonomous decision-making in women about their reproductive choices. And then finally, state-sponsored reproductive coercion is a more specific thematic framing for this research under the umbrella of reproductive coercion. And this term helps to identify modes in which the state exerts coercion on the population level. Generally, this coercion is more covert than overt. So first, I want to go into the health significance of CPCs. And I think that sexual education is a great example also of state-sponsored reproductive coercion. So CPCs do only abstinence-only education. And as we know from previous research, abstinence-only education reduces the efficacy and choice and autonomy within adolescents and young people's choices to have a child, and to have a child, and when to have a child, as well as understanding about STI, STD. However, CPCs are also funded by this federal and state level to provide education in public schools. And this is a good example of state-sponsored reproductive coercion in which the nation state, not the state as in like Illinois, Iowa, are using specific means to perpetuate a specific understanding or normativity within sexual understanding. Next, we have misinformation as the key health significance of CPCs. CPCs have been known to provide lots of misinformation through several different studies. This has been traced. More anecdotally, I went through all the different CPCs in Illinois, and a lot of them have different manuals. And often they overstate the pain, negative results, and impact of future fertility of abortions for people who are seeking abortion as a way to help stigmatize abortion further. And then finally, over the past 5 years, CPCs have been using more STI and STD treatment, testing, not treatment, as a way to get people into the door. However, they don't offer treatment or referral services. This makes it more difficult for people to navigate an already complicated cascade of care for things like HIV and STI treatment. So they're providing information, but no tools for people to help navigate that situation. And then just to highlight the health significance and the poor results from CPCs. We have several organizations that condemn CPCs, including the Society for Adolescent Health and Medicine and the North American Society for Pediatric and Adolescent Gynecology. Next, I want to talk a little bit about the nonprofit status. So we're going to get a little bit more about the taxes and the policy aspect of it, but it does relate to health. So in order for a health clinic to get the nonprofit status, and the nonprofit status is beneficial because you're tax exempt on both the federal and a state income tax. According to the guide sheet for hospitals, clinics, and similar healthcare providers, that health clinic has to accept either or Medicare and Medicaid. And this provides a few barriers for abortion clinics. First of all, Medicare does not include reproductive health care. And if it did, it could not include abortion care due to the Hyde Agreement. And then in the Midwest, only Minnesota and Illinois have expanded their Medicaid to include abortion coverage. And Minnesota is still a little bit more restrictive, but Illinois pretty much covers abortion if you're eligible for Medicaid. Even with that happening, which is great, there have been no freestanding abortion clinics in Illinois that pursued the nonprofit status due to state hostility and issues with the Hyde Agreement. I will say that all Planned Parenthoods are nonprofits, and there are Planned Parenthoods that offer abortion in Illinois. However, if you look closely, Planned Parenthoods partition their services as to not cause any confusion with when they're performing abortion versus other things like breast exams. So now I want to go over into my methods a little bit. So first, I identified all nonprofits in Illinois through the IRS. This is all open to the public because as a nonprofit, you have to be open about your finances. So I pulled all of the Midwestern nonprofits from the IRS and then searched for just the Illinois nonprofits. I then compared that to 97 CPCs that were identified by the Crisis Pregnancy Map Center, which is an initiative of the University of Georgia to map all CPCs in the United States. I found that that 2 CPCs were no longer active in Illinois and 17 were under larger umbrella organizations. And this means that either the CPC was registered under a church, that church had the nonprofit status and the CPC did not, or the CPC was under a larger national organization. So for example, Birthright International is a huge CPC network that works actually internationally, not just nationally. And so it's not registered as a nonprofit in Illinois. However, those CPCs do have nonprofit status, but just through Birthright. I then applied the federal tax income as well as the state income tax to the overall gross income, taxable income from the CPCs, which is again, all public facing and available to the public as part of federal legislation on nonprofits. And then I also wanted to compare CPC zip code data with demographic data. So I pulled demographic data from the American Community Survey and compared that to zip code data for both abortion clinics and CPCs. My first result was the financial result. So first we had our 97 brick and mortar CPCs. Of that, only 42 had their own nonprofit tax exempt status. And this figure on the right, I know it's a little bit busy, but it does help kind of illustrate that the amount of money that each CPC is saving, and this is in 2020. And you can see the high variance in how much money each CPC saves, and that goes back to the grassroots marketing of CPCs. But overall, CPCs in Illinois saved almost $5 million in 2020 by not having to pay federal income tax or state business income tax. Overall, they saved much more on the state income tax exemption with an average mean of $56,000. And they saved about $18,000 on average from federal income tax exemption. So these are not small numbers that are being saved due to this specific legislation. The second result is about demographic data. So on the right, you can see a spatial visualization of the CPCs and abortion clinics in Illinois. Abortion clinics are in orange and CPCs are in blue. And the population density, the width of the circle demonstrates the population density of each zip code. So the first finding that I had were that CPCs were concentrated in or around zip codes with abortion clinics. As you can see, there's only one abortion clinic here that doesn't have a CPC directly over it or on it. You can also note that CPCs have outlined the border of Illinois. This has to do with where Illinois stands in relation to the Midwest. A lot of people come to Illinois to receive abortion care from neighboring states that are more abortion hostile. The second finding was that CPCs were concentrated in low density areas. While this is true, a lot of CPCs have been trying to move into a mobile clinic model. Two CPCs have made agreements in Illinois, have made agreements with the Stork Bus, which is another nonprofit that provides mobile clinics to CPCs for them to be able to increase their outreach. And 3 other CPCs in Illinois are working on getting the funding for that. So that will be something that will change in the future and will be interesting in contrast to how people are getting abortions in the future. And the third finding were that CPCs were concentrated in zip codes with majority low SES residents. Again, that's likely to alter and change a little bit with the advent of mobile clinics. So some limitations I would like to highlight. I use zip code data versus clinic demographic data or census tract data. I think it would have been more interesting. I unfortunately did not have access to the clinic demographic data to see who was actually going to the CPCs, and the census tract data would have provided some more close-up accuracy of the demographics of where the clinics were located. I also only did a taxable income audit versus a complete financial audit. A complete financial audit, I don't have the expertise for, but just briefly looking over it, it would provide an interesting look into how CPCs are working, as most of their employees are actually volunteers, not paid. So looking at where that money is going to would be a very interesting endeavor. Some next steps. As we can see from the financial findings, the state income tax was the one that was providing the best benefit for CPCs. NFPs or non-for-profits are mostly regulated on a state level rather than a federal level. So there's precedent already set where states can change the way that nonprofits are distributed. That being said, so there could be an option in which states would, maybe abortion-friendly states could reduce the nonprofit status for CPCs if maybe they're providing misinformation. I think also monitoring of mobile units will be an essential endeavor going forward in both the realms of academia and advocacy, and provide an interesting juxtaposition when we look at mobility, state mobility in the future. Thirdly, CPCs do provide a type of care. They provide diapers, they provide clothing for infants, and they get Title IX funding for this. This care is coercive. You have to go to classes in order to get this kind of financial and physical care. However, I think it's something that we need to examine as both the research community and as a society to look at why these CPCs are kind of providing that whole in care and how we can create better means for care. And then finally, just highlight some gaps in research. We don't have much research asking people who go to CPCs about their thoughts and feelings about the CPCs. And finally, in conclusion, especially in light of yesterday's article that came out from Politico, as abortion clinics continue to close throughout the United States, the state's roles should be acknowledged and examined in access to full spectrum reproductive health. By favoring access to the 501c3 status for one type of reproductive health space over another, each state contributes to the continued delegitimization of abortion care in the United States. In doing so, state-level policies ensure the continued legacy of state-sponsored reproductive abortion within America. And that is my presentation. Thank you everyone for listening. I really appreciate it.
Thank you, Madeline, so much, and very timely.
Unfortunately, so yeah.
Yeah. Mm-hmm. Really great job. So I will open it up for questions. And again, feel free to use the chat or unmute yourself, or you can raise your hand, all 3 different options. So Madeline, while we're waiting, I'm just wondering, like, where do this was really, I thought, I mean, it's so timely. Where do you think this goes to Illinois? Like, is like, what's your dissemination plan even for this, or have you thought about that?
Yeah, so I am a case manager for the Chicago Abortion Fund. So I work with people every day. So we're looking at ways to better educate people around us about CPCs and people searching for it. I think that it will be really interesting when we see CBCs are so unregulated, they're allowed to cross state borders with their mobile clinics in a way that abortion clinics can't. So it'll be interesting to figure out a way to actually monitor them. And I would hope to provide some type of like counter education on how they're accessing people. And there's a lot of concern about that in just general within like the abortion care world. Yeah.
Mm-hmm. Great. Any other questions? I'm not seeing any. All right. So Madeline, again, thank you so much. Great job. All right. It's now time for our last presenter of the day, Matthew Rigsby, and he graduated with a Bachelor of Arts degree from William and Mary, and he majored in international relations with a minor in Hispanic studies. So Matthew, you can take it away whenever you are ready.
Great. Yeah, just trying to show my slides without the screen share on front of me.
Yeah.
Sorry.
Do you see
Give me
the?
one. Yeah, no, I see it. Hold on a second.
While you're doing that, how about if I read your title?
Yeah, that would be great.
Okay, his title is called Future Directions for Sexual and Reproductive Health, a scoping review of evidence on utility and the use of online to offline interventions in low and middle income countries.
Almost got it, I promise.
No worries.
I'm beginning. Great. All right. So as Kristen Mari so kindly read my title, I'll be talking about online to offline interventions in low and middle income countries. So to start, what is an O2O? An O2O intervention is an online to offline intervention. O2O interventions are often used in e-commerce and are defined as an online to offline channel where merchants use online operations to spur offline purchases. Why do we care about this? In public health practice, O2O interventions include programs that provide online channels for accessing healthcare, which subsequently connect individuals to in-person clinics or health services. For example, an O2O intervention could include an HIV-related program that offers counseling one-on-one virtually and generates linkages to quote-unquote offline / in-person clinics for testing or further services. First, I want to define e-health and m-health and talk about how O2Os are different. E-health is defined as delivery of healthcare using modern electronic information and communication technologies when healthcare providers and patients are not directly in contact and their interaction is mediated by electronic means. M-health is very similar, but it's medical and public health practice supported by mobile devices instead of a desktop connection. Where O2Os are really somewhere in between. They have an interactive online intervention that leads to an uptake of an offline source, right? So this isn't just an e-health intervention that is a blast of information. This is something that actively engages the user and then connects them to an offline source. So why do O2O interventions matter for sexual and reproductive health? First, they're increasingly relevant in the age of socially distanced health interventions. As COVID waves continue to come and go, we've seen a lot of health interventions that were normally in person be translated to online. I believe this will probably continue. And so online interventions can be a great way to cut down on the spread of COVID. Another reason is personal preference. And as we are entering a more and more digital age and more online age, some people prefer to get their healthcare online. We've seen a rise of telemedicine, and while O2Os are not exactly telemedicine, I think it demonstrates that there are people who prefer to get their information and services online. Another reason is that it increases access. When things are online, people who maybe don't normally have access to a 9-to-5 health clinic can have increased access. It also creates flexibility for seeking care, right? And it's especially relevant to low and middle income countries with internet access. So I just want to show this graph real quick to show that internet access is increasing, not just in the developed world, but in the developing world as well. And this is a trend that I expect to continue. And so what do existing interventions look like? First, there is a sort of O2O intervention in our own department called My Plan that helps you identify, navigate, and provide resources for a range of relationship abuse concerns, all done online to provide you to offline resources. Another more relevant example to this presentation is a program called Adam's Love, which was launched in 2016 by the Thai Red Cross and was designed to increase PrEP and HIV testing uptake among key populations in Thailand, specifically men who have sex with men and transgender populations. To go into a little more detail, the website is kind of a one-stop shop for HIV education, counseling, connection to testing sites, non-financial incentives to increase engagement, and online messaging boards. Users take to the site, they're encouraged to review educational materials. They later partake in counseling with a trained non-medical counselor about HIV risk factors and other STI risks. Once connected to a counselor, they are connected to an online booking system where they can schedule an appointment at a free PrEP or HIV testing center, the offline portion of the intervention. This program was especially successful in increasing uptake of HIV and PrEP services and can serve as a model for future interventions. So the objective of my master's thesis was to summarize the literature and research on online to offline interventions associated with the uptake of sexual health services related to HIV or family planning in low and middle income countries. Search strategy, so I used the databases PubMed and Scopus. My inclusion criteria had 4 aspects. One is that it had to be related to sexual and reproductive health. Another one is that it had to be an actual intervention, and that it could be an RCT, it could be a program evaluation, what have you. Another is that it had to be included, another concept of inclusion was that it had to be in a low and middle income country. And the last one is that it had to be an actual implemented online effort with an offline component. I won't get into the weeds of the entire search strategy, but here is the breakdown of my sources. I ended up getting 3 from Gray Literature, 1 from FHI 360, and a couple from a Snowball search, as well as 4 RCTs, 2 in Vietnam, 1 in Thailand, and then 1 in Mexico. So what are the findings? First, it's limited literature. So as evidenced by the 6 sources I found, there is not much literature on specifically online to offline interventions related to sexual and reproductive health. This wasn't entirely surprising to me, but it does reinforce the notion that there could be more literature and more evidence. That being said, there is some evidence that can be gleaned from mHealth literature, specifically in what makes these interventions work. There are 3 main aspects. One is a push messaging system. So connecting people to resources and then offering to actually like schedule the appointment for them and have a sort of a push effort. Another is tailored information to key populations. This was a key aspect of all the interventions I found. They targeted specific populations, most commonly men who have sex with men and transgender populations, and tailored information that was special for them. And the last thing that works well is interactive communication. This maybe isn't a huge surprise, but when there is a back and forth, whether it is a chat bot on the other line or a trained counselor, people are more likely to stay in this sort of ecosystem of information and hopefully uptake services. And then the evidence from the SRH specific O2O interventions is that studies show that it's possible to have an online intervention that is tied to a physical health clinic that can prompt an offline response. After e-counseling and dialogues, key populations are more likely to get tested for STIs and HIV, take PrEP, and schedule regular visits. So this has an extended reach. This affected populations that are traditionally underserved and increase the uptake of services. So the last thing I really want to discuss is what are the potential for O2O interventions and what are the limitations, given that this is a relatively high level scoping review. So potential, I talked about a bit, but I'll go into more detail, that you can reach more people online than you can with traditional public health communication. I'm thinking as the internet access becomes increased, especially in the developing world, you can reach more people on the internet than TV ads or radio spots, right? This is obviously context specific, but in general, you can get more eyeballs this way. You can also increase access to people who may not be able to easily access services. I'm thinking of people that work 2 jobs and are busy from 7 a.m. to 7 p.m. and cannot get educational services if they're curious about getting a family planning method. They can get this information and schedule an appointment online so they can cut down the time needed to actually get the intervention. And the loss potential is greater uptake, right? That's why we're all here in public health, is to like increase uptake of services to improve population health. The more people uptaking services, the greater access, the healthier the population. And I think the online to offline interventions can definitely contribute to this. Limitations. So the first and most obvious limitation is that this is not applicable where there's not widespread internet. This may be more applicable in urban centers with better internet connection, or LMICs, maybe like Vietnam or Thailand, that have high internet connection across the country. Another major limitation is technological literacy and barriers to actually using an application. I'm thinking of people don't always want to download another app on their phone and make a new password, a new username. They may have difficulty navigating the app or browser. And the upshot of this is that this skews towards excluding older populations, as younger populations are more likely to be technologically fluent. The last, and I think the biggest limitation of online to offline interventions, is monitoring and evaluation challenges, right? So how do we capture who is actually uptaking services from the online source? We can track page views, we can track clinic visits, but how do we make that connection to know that our intervention was actually successful? This is especially relevant as there's become more and more focus on monitoring and evaluation in public health. Some suggestions that I had thought of might be geofencing, using vouchers, using QR codes from the app to present at a clinic. Basically, this requires a large amount of coordination between creators of the online to offline intervention and people that are actually receiving the offline people in their intervention. And last, I want to talk about what's next. So as I mentioned before, there is not a huge amount of literature. So I would recommend more studies, even bigger studies. A lot of the RCTs I had the number of people in the study was maybe like 50 to 75. So increasing the size of these studies, and then maybe piloting more programs or extending existing programs to try in new contexts. So with that, these are my references, but I also want to take a moment to acknowledge the support of my cohort in doing this, my wonderful and lovely girlfriend, Kelsey Williams, in supporting me in a lot of late nights and bringing me a lot of Diet Coke. And also my advisor, Celia Karp, who was immensely helpful in editing, scoping, hand-holding through this entire process. I could not have done it without them. And with that, that is the end of my presentation, and I will field any questions.
Wonderful, Matt. This is awesome. So again, I will open it up to questions at this point. And I see one right away. Beth Frederick, you have your hand up.
Oh, be nice.
Yeah.
When have I ever been mean, Matt? So you said that our field has very little literature on this, on telehealth. Did you find other fields that were more robust in terms of their background materials?
Yeah, so I found that public health had a lot of adjacent materials, like you mentioned, telehealth, e-health, mobile health. It's most common in business. This has been the big push, especially since COVID happened, of how to create online engagement for e-commerce to get people to go to your store, to have an offline uptake of your services. So I spent a lot of time in business journals, which was helpful in scoping out what these could look like, but definitely struggled to find information within our field.
Great.
Thanks.
Other questions? I guess while we're waiting. So Matt, I have a question about and maybe it's too tough to answer this because we just don't know, but are there areas of sexual and reproductive health that lend itself more to this type of O2O intervention?
Yeah, definitely. So I go into this a bit in my master's thesis, but the idea is that So HIV and PrEP uptake, testing, those services definitely lend themselves to an online educational portion and counseling that goes to an offline uptake. But what I had in mind almost throughout all of this was that this could be a good way to do education for family planning methods, so that people who may not be able to access services don't have to wait for a health educator or health promoter in a crowded health center. But if they have a mobile device, they could receive online e-counseling on what method might be best for them. So they come in already informed to a possible doctor's appointment. So learning that you maybe want an IUD before you come into the clinic and decide you want one, I think would lend itself well to it.
Okay, great. And so so knowledge and counseling, kind of the main routes that this goes.
Yes.
Okay, great. Thank you.
Thank you.
Other questions at all? Feel free to raise your hand or just type in the chat. We have 1 more minute, so plenty of time.
Just trying to run out the clock here.
Yeah, I'm really, I don't know if we're gonna, oh, Susan, okay, yes.
Great job, Matt. One of your last questions really made me think. So we've been working with the WIC program and how to drive people to websites, and one of our sub-grantees. And Google Ads was a big way to drive people to a website. But we also found in a different project that even if we could get people interested in a program, like you said, some of these programs have very strict criteria for who can be a part of it. And it makes it a big challenge for, we want to offer services, but do we have to build capacity for those programs before we can start doing a large scale recruitment?
Yeah, it's that's definitely a challenge. I think that's a real barrier for a lot of these startup programs. I think that, I'm sorry, can you repeat your question? So
do we need to build capacity for these programs before we can do a large scale recruitment?
Well, that's $1 million question. I would say yes. I think there's definitely merit in building capacity before doing these programs, right? So they should be, I think about them as an extension of existing programs that are already out there. So like one of the programs that I found was an implementation arm of the Thai Red Cross. And so building that sort of capacity both among staff and local partners before doing so, I think was definitely beneficial.
All right, well, look at that. We're at 1:21, so we made it. Matt, wonderful job. Great, great, great. And to all of you that presented today, it was just fabulous. I learned so much. So way to go, everyone. It was just wonderful. So everyone, we're going to be doing this again tomorrow, and there will be 3 presentations tomorrow. So stay tuned for more. And on that note, I want to wish you all a wonderful Tuesday. So take care, everyone.